Okay, so I think let's start the afternoon session, and we look forward to a wonderful conclusion to the day. Over to Chelsea.
Thank you, Timothy. We love those energizers. Good afternoon, everyone. I'm very fortunate to get to introduce our next speaker. Dr. Samuel Chizito is a PhD candidate in the Public Health Sciences program at the Brown School of Washington University in St. Louis. He's a physician epidemiologist interested in research methodology. Dr. Chizito's work focuses on designing and evaluating public health interventions to improve outcomes among youth living with HIV in low-income settings. He has expertise in examining treatment efficacy and studies with longitudinal nested data, assessing the effects of interventions on treatment outcomes. He has previously used advanced statistical methods, including multi-level mixed effects modeling, generalized estimating equations, hierarchical linear modeling, survival analysis, latent growth curve modeling, and structural equation modeling to assess the impact of interventions in our NIH-funded studies on treatment outcomes among adolescents and young adults. And most importantly, Dr. Sam is defending his dissertation tomorrow. Let's please wish him good luck.
Good afternoon. Yeah, it's always a challenge when you have to talk about statistics, moreover, in the afternoon, when people have just had lunch. Yeah, but I promise you, I'll try to keep the statistics at their minimum. And I don't think the name actually does the topic justice. Basically, what I'll do today is to try and showcase some of the methods that we use when we are answering research questions at CHILD. And in doing this, I'll try to show some common pitfalls that people land into when they are doing research, especially analysis, by ignoring some of the basic principles. I guess I have to stay here. The technology is letting me down. I prefer walking around, but I'm being led to stay here. So one of my weapons is already taken away to keep you awake. Okay. So the first question is why the topic of advanced statistical methods, which what I'm going to talk about today. And I'm going to say that this session is more of a crash course. There is no one method that I'm going to tackle, which I'll go into. Maybe those deep details that by the time you leave here, you're very conversant with how to analyze using generalized estimate. No. But one of the best classes I think I've ever attended, and this was during my master's training, was a course which basically introduced me to various techniques that are there to analyze data. So basically it kept telling me there's this method, you use it for this, there's that, you use it for that. And I think it's important as well to do the same here, especially that we have various groups of people. Even if you're not a statistician, when you know the best questions to answer, when you know what kind of technique to use to answer, it puts you in a better position as a researcher. As I always say, many times we say that data is rich. That statement is not complete. Data is only rich, but as rich as someone who is manipulating it. It's possible to give two different people the same data set. One gives you trash and the other one gives you gold. And part of that is for you to be able to know what types of questions to ask, what types of analysis to use. So this session basically is to take us through some of the advanced techniques and why we need the advanced techniques. And just as a little bit of overview of this presentation, I'll take us through the common ordinal least squares method, which is like the mainstay for regression analysis. And from that, I'll build onto it to try and understand how other methods come in. And what you see down there are the other methods that I will show you how we have been able to use this in our work in iChad. For the start, let's begin with the ordinal least squares regression method. And what I always say is what we do in quantitative research or statisticians is we try to reason out the real world in terms of numbers. And although we never realize it, it is true actually the real world has a lot of numbers to do with it. That's how people predicted that yesterday there will be an eclipse at that exact time. We know a day has 24 hours. We know a year has 365 days, etc. Those are all statistics. In the same sense, when you go out and you collect your quantitative data, and then you turn it into numbers and you go on the computer, you try to create some kind of equation out of that data. And you use that equation to answer your questions. To give an example, I can do a simple study here. And I say my outcome is going to be the number of people who will doze during this session. And then I will have my predictors. Those who had lunch, those who traveled from abroad, those who, among other factors, those will be my predictors. Out of those variables, I'll create an equation where my y, the outcome, is dosing. My predictors are travel, having lunch, etc. What you see there in red, that's why I want to point. Can you see the pointer? That's why I hate being. So, yes, when you see this one here, this y is the dosing. What you see here is whether you traveled, etc. And this is actually an equation of a straight line. But in reality, for you to convert real world into a straight line, it's impossible. So what we do, we put there assumptions for you to use real world into a straight line. Now, every time you have data and you violate those assumptions, it means what you're getting is actually wrong. And that's where we say garbage in, garbage out. And I review for journals, and many of us read papers. Sometimes you get results and you really see this is bogus work, but it went through the review process and it got published. But many times you submit your paper and they keep bouncing it from here to there because what you're proposing doesn't make real sense. So here I give an example. This is a simple study where the main predictor is time you spend studying. And your outcome is the score you get in an exam. And if you have about 15 participants, maybe, this is how their scores may be distributed. You find participant 1 maybe spent 1 hour studying, and their score is 3 out of maybe 10. And you find a participant like this one, spent 6 hours studying, and you see that their score is around a 9. So someone can come and say, if I want to fit a line here, which best represents this sample, which way can I put it? And I can say you can put it here because you see some points are distributed above and others are distributed below. So they are evenly distributed. And someone can say this is the best fit. However, another person can come and say this is a better line because some points are here and other points are here. The question is, which of the two do we take? So many people are saying the second one, which seems reasonable, but the question is why? It's true that it seems logical that the second one is better, but the question is why? The points are closer to the line, yes. So it means when you look at, and I gave you a hint here, but when you look at how far these points are from our line, many of them are very far away from the line. So it doesn't predict our data very well, like this one, where many of the points are closer. So to put it simply, what we mean by least squares, or no least squares, we want to go with a line where the distances of these points from this line is the smallest. So that's what basically least squares means. And that's why you hear ordinal least squares regression. Building onto that, to use that type of analysis, these are the assumptions I talked about. One, although here I use the model residuals to put it into simple terms, people usually say your outcome must be normally distributed. There are people on the extreme on the left, some people on the extreme on the right, and the majority are within the center, which is basically what happens to deal with an outcome from the real world where you have a lot of data. But when you have small samples like the ones we deal with, many times this assumption is violated. So for us to basically avoid falling into that, this is where we calculate sample size to ensure that we have enough participants. The other assumption is there should be minimal or no multicollinearity. And this is going to become important in my next few slides. So basically what we mean by multicollinearity is when you want to understand a sample and you get your information on the predictors, I talked about dosing, I talked about eating lunch, you don't want to get two variables which move together, like such that when this increases, also this increases. When this reduces, also this reduces. If I'm doing a study on maybe tuberculosis, which is what I used to do before I came to iChat, and you know tuberculosis, some of the risks include like crowding. The more crowded you are, the more likely you are to get TB. And then you assess a variable like your living status and you ask, how big is your house, maybe in square feet? And then you have another variable, how many rooms do you have in your house? Chances are high, the bigger the house, the more number of rooms, and the other way around. Those two variables are correlated. The question is, if you find that maybe the number of rooms is being significant, is it the actual number of rooms or the size of the house? But also, it means that if you have information on one, you don't need the other. So this is another one, and we shall see when it becomes important. The other one is the constant variance. And when we talk about constant variance, I'll give also an example on this. I'm spending a few minutes here because it informs basically the rest of my presentation. If I'm looking at an outcome of maybe body weight, and I'm doing my simple study where I want to see what factors predict someone's body weight, and I include many variables, and one of them being the participant's age. And I find that, yes, as the age increases, also the body weight increases. That is a significant association. But in my sample, I collected a variable of age, and I included children from 0 ages basically to 50 years. And then I include it as one variable without categorizing. When I come to interpret, I will say maybe for every 1 year increase in age, the weight increases by 2 kilos based on my results. But is that true in reality? Because if a child has 1 year and they become 2 years, yes, they may increase by 2 kilos. But is it the same for an adolescent or an adult? If you're 50 years and you become 51, you still increase by 2 kilos? If the answer is no, then there is no constant variance. But if the answer is yes, then there is constant variance. So you have to think of your variables as you put them in your model. The other issue is linearity. This, I won't spend much time on it, but every predictor should have a linear relationship with the outcome. That's why we fit them on that line, which we saw. And then the last one I'll talk about is something we call dependency. And this is important such that basically the factors that work on me in predicting the outcome should not influence the factors maybe that work on Vincent in predicting the outcome. When we go to recruit participants, we want to include participants who are not related to one another in any way. That way we maximize information. But if you come and you recruit Chizito, Then you recruit Vincent, who are in the same school, same country, same everything. Chances are high by the time you reach Vincent, if you interviewed me, you have some of the information I would have told you. So that limits how variable your sample is. To make it even extreme, which is not real, assume you clone Chizito into 200 Chizito. Same age, same size, same like, same dislike, same everything. And you say I have a sample of 200 people. Do you think you can answer any question? No, because we are totally dependent. And every time you have anything that affects dependence, it affects how you can answer your questions. So I want us to keep these 5 in mind as we move through the slides. Remember, the point was to show how we use some of these methods in our work at iChad, and we're already diving into this. So this paper here that I'm presenting first, I led it, and we used what we call hierarchical models. In essence, this is the linear regression that we are talking about, but we extend it for a variety of reasons. And what we do here, for you to use this type of model, and I think this will be also important for the scholars as you think about your questions, because many times we see papers on prevalence factors associated, and although it is necessary, I feel it's not sufficient sometimes. If you have a rich data and all you can do is prevalence factors associated. This type of model, you have different models, but you introduce predictors as blocks. And this is important in our work at iChad, for instance, because we implement interventions which are multi-level. At family level, for instance, or at individual level. So I can decide to do a model, and I say if my outcome is sexual risk-taking behaviors, I could know that there are factors at the individual level that can influence whether I will have risky sexual behaviors or not. Or there could be factors at the family level and stuff like that. So you introduce at each level factors at that point. So this is basically an extension of the ordinary least squares method. And this is something you can think about, because eventually what it tells you down here, although the letters are small, it tells you which factors at each level influence the most the outcome you're looking at. And in that essence, it can tell you if you are to design your intervention. Do you want to address at the participant level? Do you want to intervene at the family level, depending on which one performs the best? Does this make sense? Now, many times the assumptions of linear regressions that we talked about are violated. And here is where the advanced statistical models come in. Basically, they were developed to try and address the violations of the other assumptions that we talked about. One factor that always comes in is what we call clustered data. And what do we mean by clustered data? When you come, for instance, to iChad studies, we recruit participants either from schools, and not one school, but many schools, or from hospitals. You find there's a study where we recruited participants from 39 to 40 hospitals, or even hotspots like the Chartered study where we have hotspots of sex workers. The issue with that is that when you come from the same hotspot, or when you come from the same hospital, you are related inherently to one another than when you come from like different schools. And those of you who come from Uganda, for instance, you know, there are those students who are Budonians, or from Namugongo, and they have traits. So when you look at someone with an afro who is laid back, something like that, they can tell that one is from this school. It's true in real life. And even when you go to like hospitals, there are different levels, health center 4, health center 3. They have maybe different levels of clinicians. You find that participants who go to one hospital have something in common amongst them than those who go to another facility. And that something which is at the hospital level, may influence your outcome, unlike what you're looking at the individual level. So that's basically what clustering is about, and you need to address it. The other factor I talked about is multicollinearity, whereby as one moves, maybe as one increases, the other one also increases. When we do longitudinal studies, for instance, and you have your 500 participants, and you go 1 year, you assess the outcome. You go the second year, you assess the outcome again. Those repeated measures of your outcome are correlated with one another. So the independence is lost. And this is another factor you have to bear in mind with. So that is one reason why we usually go for advanced models. But also, besides that, sometimes we go to advanced models because the types of questions that we are answering can't be answered by a simple linear regression. For instance, you want to assess associations maybe, or frameworks, and that's where you have to go to things like mediators, etc. And I will give you an example in a short while. So I already showed you my overview. So we are moving to one of our advanced models, which is one of the commonest actually that we use at iChad, given that we have these longitudinal studies. So the reason why we call them the multi-level or mixed effects models will become apparent in a second. I explained already this, that many times you have a hierarchical nature of your data. Here I gave an example of a hospital. You may have one hospital, but it has several doctors. Doctor 1, Doctor 2, Doctor 3, Doctor 4. And each doctor sees different patients. But as a doctor who practiced, I can tell you some practices that I used are not the same practices that another doctor uses. Even when you went to the same school, even when you were in the same, eventually those changes come in. If we are treating maybe patients and we give them the same surgery, you may find that my patients heal faster. I won't say heal slower. Mine may heal faster than maybe Dr. Rachel's patients. So it may not be the patient characteristics causing that, but the hospital characteristics or the doctor characteristics. So that type of clustering, you need to be aware of it. And it can go beyond 2 levels. You may find that these hospitals are also many. So there is factors at the hospital level. And you find that the hospitals are also in districts where one district is a city, which has a city council care of them, while another one is in a rural municipality. So you can go as many levels as you can. So on this slide, all I can say is once you have those types of hierarchies, as I explained, there is no longer independence. Participants in one hospital. So, yeah, I've explained this luckily. When we deal with this type of models, I'm trying to get one example. So this is a paper which was actually led by Dr. Josephine down there in the corner. And basically we looked at the relationship between family cohesion and depression among school-going children with elevated behavior changes in southern Uganda. Any other person could have easily gone for simple linear regression. But knowing that our participants were recruited from so many schools, we anticipated that the fact that the students were from many schools, there could be some correlation, which I was talking about. And indeed, when you look at our results here, what you see me as calling here the null model, when you look down here at what we call the random effects, these are statistical, but basically they tell us that yes, the students from the same school were actually correlated. And as long as you see something, here eventually there is a statistic called the ICC, intra-cluster correlation. If it's more than 5%, it means using simple the results you get are wrong. It's basically to say there are associations when they are not there. So after seeing that it was actually clustered, that's when we went ahead and ran our models and went ahead to interpret in the same way that treated. I don't know why it keeps going on. So the beauty with being this critical is it's actually rare that when we submit our papers, they get rejected to journals, and that I will applaud our team. Because when you're rigorous, your work gets cited a lot, but also your review process is smooth because you're rigorous anyway. One step ahead of that hierarchical nature that I talked about is when your study is longitudinal. And I hinted about this already. When you do repeated measures, they are also clustered. So the model I showed you on the previous slide from a paper that was led by Josephine, you can also extend the same model for repeated data, for data which is having repeated measurements. And for those of you who analyze your own data, the trick is, while for the previous model, which was cross-sectional, your data is in a wide format. But when you come to do the same model for the longitudinal data, you have to convert your data from wide to long format, and then you can proceed to do the details. Unfortunately, like I said, I can't give every detail in a 1 hour session. So those of you with longitudinal data sets, maybe we can talk outside this session. Here I give an example of our paper. Actually, I think this paper came out this January this year. And I read this particular paper. It's from one of our studies called the Soviet adherence study, which recruited adolescents with HIV, and we have been following them for several years. And the outcome here was adherence to their HIV medication. So we measured adherence at multiple time points. But our question was whether our intervention was effective in improving adherence. The fact that the measures were repeated, we had to adjust for that. And not to bore you with the tables, we generated a simple figure, and what you see here in blue are participants in the control group. On the x-axis, these are the multiple time points we followed up our participants to measure their adherence. And you can see that the intervention group, as time went on, their adherence actually improved. Well, for the control group, it continued to reduce. Basically, our intervention was effective. And you can generate also some nice tables. You see here that as time went on, participants in the intervention group, these are odds ratios, they reported higher adherence compared to those in the control groups. So these are some of the fancy techniques you can use, especially those of you who are doing trials or longitudinal follow-up studies. So generally, these are called mixed effects models because they give you the fixed as well as the random effects. A similar but a bit simpler technique you can use is what we call the generations. So once they also have the ability to control for that clustering, but the models look almost similar to the simple linear regression models. They just extend that structure. And when you go to your analysis programs, like in Stata, it is basically simple. You declare your data that this is survey data, and it will ask you what is that variable which clusters your data, and you tell it maybe it's the school. And then you can go ahead to run your models. In this, I will show you one study which was led by Dr. Joshua Chiyingi, who actually defended his PhD last week and was here yesterday. In his study, he wanted to look at the predictors of mobility among women engaged in commercial sex work from one of our studies called CHILD-GRF study. Here we had some kind of dilemma because by the time he analyzed this data, the intervention groups had not yet been revealed. So we, as the people who are working on the paper, were blinded to the interventions. Yet the fact that our outcome mobility, you can only measure it at repeated time points. There is no way you can do analysis on a longitudinal study and you don't control for the intervention. So we had to use longitudinal methods, but conceal our interventions. That's why we used the generalized estimating equations. We also included the intervention, but we didn't what? Unblind. So we don't know. Basically, we could do this and you don't unblind. One difference between this type of generalized estimating equation and the previous one is the estimates this one will give you are usually population average. So you interpret in terms of the population where you got the sample from. Whereas from the mixed method, you interpret according to participants in your data. Yes, another method which we have previously at our work in iChad is survivor analysis. And with survivor analysis, like the name suggests, it originated from many studies which were on outcomes to do with survival, especially with cancer studies, where participants were followed up and over time determined how many survived, how many died. However, these type of models have been extended to also other studies like behavioral studies, etc. And here, the trick is that the outcome is not maybe surviving or not surviving per se. It is time to that outcome, which actually provides a lot more information than just looking at the outcome as, for instance, survival alone. Because someone, if you do a study and you follow up people for 5 years, and someone, for instance, unfortunately died at the 4th year, when you just do survive or die, they will be in the died group. But surviving 4 years is important. You'd gain a lot more information by understanding why someone survived 4 years versus why someone just survived for maybe 3 weeks. So when you do have data that has follow-up, you followed up your participants for a given time. This is one of the types of questions you would gain a lot of more information in doing by asking, what is the time to my outcome? And it can be a paper by its own, different from a paper about maybe my outcome itself. So I led a paper from one of our studies, so we had adherence study, and the same study I described for children with HIV. And I looked at the impact of the SUVI adherence intervention on academic outcomes. And my academic outcome that I was looking for was time to school dropout, not merely school dropout. Wanted to see at each time points how many dropped out of school, and is that different between the intervention and the control group? So the figure you see on your right here is what we call a Kaplan-Meier graph. On your y-axis, you have the probability of your outcome. At the start, all the participants were still in school. But as time goes on, some participants drop off, and that's why you see these dents at year 1. So the more participants that drop off in each group, the bigger the dent. What you see in the blue line here, those are participants in the control group. And you can clearly see that over time, those in the control group, many participants were dropping off. That's why the line is lower. And from this analysis, we were able to tell that indeed our intervention, those in the intervention group stayed in school longer than those in the control group. Information which we wouldn't have got if we had just done staying in school or not. How much damage have I done in terms of boring you? Are we okay? So like I say, this is an overview. I want you to think about this and additional methods so that our data can generate rich questions which can be used for subsequent work. Another method which is very popular with our iChad work is structural equation modeling. Those of you who do mediation analysis, and in many of our grants when we are writing them, we always include potential mechanisms of change. If your outcome is treatment adherence, it is important, yes, to know whether your intervention directly influences adherence. But it's also important to know whether it influences it directly or indirectly. For instance, the intervention can reduce the mental health problems in your participants, and because their mental health is now better, they can adhere more. So by looking at those mediators, the best way to do that is to use structural equation modeling. And I'll give an example of, actually, this is a graph from one of our papers at CHILD. Indeed, we looked at whether our economic empowerment intervention was efficacious in improving ART adherence, both directly but also indirectly through mental health functioning or adherence of efficacy. And when you go to our website, you can see some of these papers. And these are the results from the same paper. And what we see here is when you look at these outcomes, sorry, the figures are small. You see here where it says indirect effect. The total indirect effect is significant. That's why it is in bold. And when you look at these, what I call mediators, you see that mental health functioning is also significant. Basically, what it says is, yes, the intervention directly improved adherence, but it also indirectly improved mental health functioning. And the improved mental health functioning in turn led to better ART adherence. The trick here was the intervention was introduced for the first 2 years. So we used the mediators which were measured at 2 years. And then the outcome was measured at 5 years. Because it's hard for you to say these relationships, yet you're using cross-section. However, there are also mediation models for cross-sectional data. And we have done those also before. So if you think of such questions, please feel free to reach out and we can talk more. Actually, I think one of the last models I'll talk about is risk prediction, and this is becoming very popular of late, especially with the booming machine learning and stuff. And the main difference between risk prediction models and our traditional models is that here you're trying to predict an individualized risk of something happening. And to give an example in my dissertation, which I'm going to defend tomorrow, and you're actually welcome to celebrate with me if I pass. So, amen. So we shall get together at 11:30 a.m. at Hillman 130. But my second aim, I'm developing a model where I'm predicting the risk of virologic failure in children with HIV. And this is important because if you can predict that this child is more likely to fail virologically, it helps for you to focus more resources on that child so that you prevent them from failing virologically before it even happens. Whereas when I just do prevalence and factors associated with biological failure, all it tells me is that maybe poor adherence is associated with biological failure in this group, but it's not at the individual level that this child is more likely to fail than this one. So that's where risk prediction modeling comes in, and it has a whole set of techniques that you use as you develop these models. And we have one of our papers, which was led by Dr. Rachel, who was here yesterday and this morning. And I was lucky to co-author on this paper too. But basically, she developed a model where she's predicting ART adherence. So you can use that model to tell which participant is adhering to their medication better versus which participant is not adhering to their medication. And if these models can be simplified, they can actually be used like in routine clinical settings. And for the clinicians here, I can give a quick example of the Alvarado score, for instance, which is used to diagnose, I think, appendicitis. It is something like that, whereby you can turn it into a score and you assess every individual to see how much likely they are to adhere or not. Yes, to be mindful of the 1 hour that I was given, those are some of the techniques, but the list is not exhaustive that we have used indeed in our work at iChad, but there are a lot more models that you can use, and I don't know most of these actually. The ones I've presented about, I'm conversant, and if we can have a talk, I would be happy to take you through. Some of these that I know and I've worked with, social network analysis, we have a paper with Dr. Ozgi, which is under review where we include social network analysis. Our team here is very good with agent-based modeling, also maybe difference in difference analysis. I'll end with this simple paper which I wrote. It is just a letter to the editor, whereby I was saying actually agent-based modeling, which doesn't rely on you collecting actual data. You can sit on your computer and you simulate situations. So you see, if I have some participants with HIV, what would happen if I introduce the intervention here? How about if I have many participants? How about if the adherence is lower? So you simulate on your computer before you even go to collect data from the participants, which will sort of tell you where to intervene better. So I was proposing it as a new way that we could begin looking at this problem of adherence, which has been with us for long, but it has not persisted, and it came out last year. So with that, I want to bring my show off to the end. And one thing I should tell you is this is the iChart website. And when you go to this website and you go to this window which says publications, you can browse publications per year as they come out. You just click on each and it will bring the publications. Or you can actually go to the actual studies here and you click publications by study and you can see much of what I've talked about. So with that, I want to bring this presentation to the end. So I don't know if there are any. Yep, at least we have, I think, 10 minutes. There's a question.
Wait for the microphone.
We have people.
Thank you very much. Thank you very much, Samuel, for such a wonderful presentation. I think you proved your hypothesis wrong. I actually did not see anyone dosing. But I wanted to clarify about something. So when you talked about the mixed effects model, the way that you explained it made me wonder why, or maybe that's what you are referring to. Why wouldn't you just control for for example, what the example you gave for doctors, and then the example
And you control for the doctors in your model,
yes.
it would not remove the effect of clustering.
Why?
It would not remove it because actually this is a problem which goes back even in your design as you're designing the study. By including the doctor in your model, you're treating the doctor as a covariate. You're treating the clustering per se as a covariate in your model. But in actual sense, it is not. It is causing a variability in your outcome, but at a different level, higher level than your participants. And I just didn't want to bore you with the statistics, but the way it is derived, when you do your level 1 model, which is now with the participants, actually your outcome would be now used to the higher level. And that is one way that gets it corrected. So the simple answer, it wouldn't remove your clustering. It wouldn't address the clustering by including the clinicians in your model. What would? What would is when you do a mixed model and you collect your IDs from your participant as a variable, And then your ID, you include it as another level in your data, and there are special models that do that. So you include what we call the random intercept of your clinicians within your model, but not just a mere covariate in a single model. And you have to note that it's on a different level. Whereas when you include it on the lower level, you're including it at a level where it doesn't belong. And those models can be extended because there are times when you even collect information, even on the hospital, beyond just the doctors, maybe the doctor only. You can collect the doctor's level of experience, doctor's education, and those variables from the doctor level. You can include them, but also on their own level. That's extending it.
Thank you for the great presentation. It's very enlightening. Many times when we do cross-sectional studies, it's quite hard to determine the direction of causality. Is it possible to use any of these models to determine the direction of causality before you even think of a longitudinal study? Thank you.
You're welcome. Thank you for your question. The simple answer is with cross-sectional, no. All you can do is theorize about it, but cross-sectional data, unfortunately, would not tell you information about causality. However, however, as you do your several cross-sectional studies, you can begin building theories for your eventual longitudinal studies.
Of those models that you've taught us, which one might be the best for determining the direction of causality?
So one thing is when we talk about causality, there are several methods that you can use, especially at the analysis stage, to assess causality. But the type of method that you use to assess for that causality within your data depends on the type of questions you're asking and the nature of data that you have. And here I gave examples like mixed effects models. If you have hierarchies, you have repeated measures, you want to tease out intervention, those are good models. If you have two levels within your data and you have longitudinal data, general decimating equations are good ones. If you were assessing for mediation mechanisms, structural equation modeling is a good one. And all of those will give you a good idea about causality as long as you have longitudinal data. Even the risk prediction that I talked about last, Claire Najuko, who was here in the morning, is leading a paper from our data at CHILD and is predicting ART adherence using machine learning models and is using data for multiple years. So even the predictive modeling can be used to give ideas about causality, but using different approaches.
Thank you so much, sir. I'm thinking that usually before you do a longitudinal study, maybe still social study can still guide you on what exposure or outcome for you to consider for a longitudinal study. So I think as a starter, I wouldn't be like offended if I start with a social study, then maybe I can also think about doing a longitudinal study. Am I right or wrong?
You're very right. That's why I put a disclaimer that it helps you theorize about it. But in essence, itself wouldn't tell you much about causality from a cross-sectional point of view.
Okay, we have a question from our participants online. This is Mr. Mwanguze Moses. Also kindly throw more light on long and wide formats of longitudinal data.
Okay, so thank you very much for that questions. I don't know if I'll do it justice by me talking about it. So Many times when we collect data and maybe we go to the field many times, like after the first year, and you have your information, age, sex, whatever, and your outcome. And then you go the second year and you collect the same data. There are two ways we can keep that data. One way is by stacking the years, the subsequent data on the right, like how you see the Excel spreadsheet. As you go for the second wave, you add data, the second wave on the right. So as your data increases widely, that is the data in the wide format. However, there is another way of doing that whereby every participant, so every row is a participant's entry. So you find the first row is participant 1, year 1. The second row is participant 1, year 2. The third row is participant 1, year 3, etc. Then you go to participant 2. So it increases basically longitudinally. And that's why it's called long. And there are two different formats of the same data set. There's one more hand in the back, maybe.
Thank you, Mr. Chizito. Dr. Chizito, sorry. Thank you. And congratulations also. I feel like, correct me if I'm going to try and restate what you have told us in the last hour. So correct me if I'm wrong. If I go back and I say, as long as you're doing cross-sectional studies, you may not have scientific significance in what you're doing because you don't have a lot of statistical significance in what you have done. So if I go back and I tell the average student interested in health systems research that, look for money to do some good studies that you can get longitudinal data. The cross-sectional data does not really give us a lot of scientific significance. So scientific value. Would I have misquoted you? Thank you.
Thank you very much for asking that question. And this is the juncture where I should say, if there is anyone else who picked that same message, that's not the message I wanted to pass on. And it's not what I said. Maybe because many of the examples I gave were from longitudinal studies, but I also actually gave examples of our studies from CHILD, including those that I led, which use the cross-sectional data. One thing is, even with the cross-sectional data, if it is clustered and you don't address clustering, you are telling us wrong things. Maybe that is a better message to take home. So if you're doing cross-sectional data and it has clustering, you collected your data from 10 schools, 10 clinics, and you don't do anything to address clustering, you are telling us wrong things. That is a message I would want you artists to take. If you're doing longitudinal studies, many people miss out to ask very rich, very relevant questions because they are blinded with the prevalence and factors associated. When I mentioned prevalence factors associated, I said it is necessary but not sufficient, meaning that when you do them, it's always good if you can use them to build onto better work where you can intervene. And that is from someone who is interested in interventions like myself. Thank you.
By the way, thank you so much. I didn't attend all your, but I know you're a great methods person. You're a great statistical person. So just to add to what my our dear colleague and my former, we went to school together with Dr. Mafijiri. So I think we have to be extremely careful not to confuse statistical significance with clinical significance and with statistical significance. So there is statistical significance, there is clinical significance, and then there is, whatever scientific significance. I don't know what that means. But it doesn't mean that if something is not statistically significant, that it's not clinically significant. Okay? Those are two different things. But also, it doesn't mean that because something is not statistically significant, that it has no value for us to think about in terms of rationale for moving that work forward. Okay? I'll tell you that my first study, my first publication, not first publication, but the publication out of my very first study, and which led me on, had no statistical significance. But it had trends which were pointing towards probably if this had run longer, if you had more power, I could have gotten to statistical significance. So I think that it goes to tell you that depending, of course, how you are interpreting the data, for as long as you are not manipulating the data, let the data speak for itself, okay? Look, I always tell people that losing one child, okay, may not, out of 10 that you have, may not be statistically significant, but it's clinically and emotionally significant to you. Really, and I really mean that, okay? So I think that as scientists, we have really to really figure out what is the difference between statistical significance, which you guys can read, you are all medical doctors and behavior scientists, and you are very good. Clinical significance, scientific significance, scientific rationale. What is the rationale? Why are we doing this? It doesn't mean that if you don't drive a Mercedes, that a Volkswagen won't get you where you are going. So the best rule of thumb, and really what you would call what everyone wants to do, is randomization. That's the gold standard. And the other gold standard that we have is longitudinal. That's really because that really takes you out from being a function of chance, time, and then saying, you know what, we are seeing this trend over time. So those are things that really, I may not have the answer to Professor Mashpijiri, but I think those are things that for you guys as researchers, you have to think about. And I'm sure that he really posed that question to tease you guys your brain so that you can think about it, okay? Really, so that's where I will stop.
So thank you so much. And thank you, Dr. Fred, for the additional insights.
Thank you, Dr. Chizito. We are looking forward to tomorrow. We are going to take a break for coffee, tea, and water. So please feel free to help yourselves. We're going to reconvene at 3:15. So about 10 minutes from now, but please help yourselves in the back. Thanks, everyone.
So the elevator pitch, I wanted to provide a little bit of a background about what this is all about. It's a concept, I don't know who came up with it, but the idea that you might run into an important person, a future collaborator, in a random place without any knowing or planning. You need to have your science ready to present to them off the cuff, quickly, succinctly, and interestingly to grab their attention. And we're giving you a 90-second elevator ride. Sometimes it's longer, sometimes it's shorter. So your judges today, or your experts and potential collaborators, are Vice Provost Mary McKay, whom we've met, Dean Dorian Traub, whom we've met, and Dr. Juliet Uwalan-Moore, who we heard from today. So we're very honored to have these experts in the room. And we're going to break out into different rooms where into groups of 4. So you each have really undivided attention of these experts in your elevator or lift. And I just wanted to provide this. We won't go through it, but this was the prompt that we provided our trainees. So it describes what the elevator pitch is. And then kind of, I think the last bullet points are kind of maybe where our judges want to kind of zero in, but who is the pitch directed towards? Your message should be crafted to your particular audience member. So it could be a funder, mentor, collaborator, someone who has something you want or will want. Keep it simple. Don't use industry jargon or field jargon. Use very simple language, unless, I mean, depending on your audience, but you might get dinged for that if you use too much really specific acronyms and things like that. Keep it short. And then the last bullet was on you before you arrived to practice, practice, practice. So our judges are going to be, they're not really judges, but I couldn't think of a better word to use. So they're going to hopefully have a follow-up question and then provide some feedback. So I think what has worked in the past is to get that follow-up question right away. And then once all 4 trainees have done their pitches, open up for feedback. And then we're encouraging all of our audience members to pick a room, pick a judge, pick a trainee that you want to follow and kind of move around with us. And so that we have audience participants in all of the rooms. Chelsea and I are going to lead, let's see. I'm going to take, I forgot who I'm taking. Oh, I'm going to go with Dr. Mary and her group to Goldfarb 333. We're going to go up the stairs together. And then Chelsea's going to lead Dean Dorian and her group down the hall and down the stairs. And then we'll come back here at 4:15. So good luck, everybody.
Okay, very good. And I have 4 names here on the slide for Dr. Juliet. Does anyone want to volunteer to go first? Or I can just pick a name. I don't see Dr. Guma yet. The less, okay. All right, get us started, Dr. Rachel. Okay, so it will be Andrew. Okay, got it. You wanna come here?
90 seconds.
90, do you want me to time you?
Oh.
Right, it should be part of it. All right. You ready?
Yeah.
Okay. Go.
Okay, good evening. My name is Dr. Rachel Naitwe, a psychiatrist, practicing with Jinja Regional Referral Hospital, where I offer mental health services to an underprivileged population with a high disease burden and low human resources. My research journey began when I looked at the impact of depression on the outcomes in tuberculosis patients, and I did publish this research in the Journal of Psychosomatic Medicine. I've also worked as a project manager for multi-country, multi-site studies based at Makerere University, where we looked at developing psychosocial interventions for severe mental illness. From this, we've published about 5 papers. And through all this research, I've been exposed to be able to complete my CHILD-GRF fellowship in time, where I looked at using computer-assisted self-interview to screen for depression among adolescents living with HIV. This work is under review in BMJ Pediatrics. Through all this research, I've been exposed to unmet needs of caregivers for people with chronic physical illnesses. And currently, I have a particular interest in the unmet needs for caregivers of people living with dementia. As I embark on my PhD journey,
I intend to co-develop interventions to address these unmet needs for these caregivers. Please do collaborate with me as I improve the quality of life for these caregivers.
Knowing that you've done this work. You have a lot of experience as a project manager, a lot of published papers around this field. I think, and so then in terms of the need, then you want to address in particular for your next step. So if in the past you were looking at computer assisted interventions to screen for depression, it seems like your next direction is unmet needs for caregivers with among people with dementia, correct? And that's sort of the journey you want to begin to embark on, correct? And so I think we just stayed there. Like, so I don't know what is going to be different or new about unmet need for caregivers. You didn't give me that. So you gave me your topic, but you didn't give me what would be different compared to every other things people have done for caregivers. Does that make sense? You didn't give me what would be the so like if when you were doing the other work with depression, you did computer assisted interventions. So that already told me something was different and new for depression. I don't know what you're going to do then for these caregivers. How are you going to address that unmet needs? Do you have an idea? Does that make sense? Like, so there are caregivers with unmet needs. They're taking care of people with dementia. Well, what are you going to do for them? Right? I don't know. You didn't tell me. Is that fair?
That's fair, but well, I think, well, from what I understood with an elevator pitch, is to get you interested in me having a deeper conversation with you.
So you want money from me? Is how I would see it. Elevator pitches. You want money from me, right? Yeah. What do you need my money for?
What do you need?
Yeah. 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 What do you need?
Collaborator is
Broad.
broad,
Yeah.
right? Or are you approaching her for her expertise? Are you approaching
Like, what do you need?
mentorship?
Yeah.
So I think
So we know your idea.
Yeah.
It's unmet need, caregivers taking care of people with dementia. Now what?
So I am looking.
and then you can add one follow-up.
Right.
So that could be your
Right.
follow-up.
Yeah. So I did hint that I want to do an intervention to address their unmet needs. Maybe what I didn't say is I want an intervention that is based on the locally available resources within the Ugandan setting.
Which is? I mean, you want the money, right? You told me local resources. You've told me intervention. Okay, so what is it?
So, well, allow me put a disclaimer as well as I answer this. So this is my PhD work, which is at a concept level, and I am thinking about a behavioral change intervention. So the details of that, I really do not have them.
Fair enough.
Yeah.
Fair enough. So that's where then the more work is needed, right? Because
Yeah.
elevator pitch is about going to ask for collaboration or going to ask for money. And so then what would the money fund? Right.
So for me, my idea was to ask for collaboration because then I'm able to finally tune to how I'm going to do that intervention from your expertise.
What do you need the collaborator to do for you then?
So I need to do this collaboration I am assuming that you have done work on dementia and unmet
enough.
needs.
Fair enough.
So the collaboration is about me being able to shape my work better and be able to conduct it.
So we have work to do, right?
Yeah.
Yeah, fair enough. Fair enough. Exactly. Dementia, right?
Working with caregivers, people living with dementia.
Exactly.
Or your expertise in dementia,
Shaping
like whatever it
ideas,
is. Right?
exactly.
So I think that just needs to be
Right.
clear.
So
Okay.
in that 90 seconds, you have your idea. I'm interested in unmet need with people living with the unmet need of caregivers taking care of people with dementia. But to do that, I need X, Y, and Z. I'm coming to you because I need X, Y, and Z. Does that make sense?
Yeah.
Okay.
Hey, some other people have some questions for her here and there.
My comment is quick in the way that an elevator pitch is quick. I have been in taxi pitches, elevator pitches, train pitches. One way you could say that is, hi, Dr. So-and-so, I am submitting a proposal. Next month, it's due August the 30th. May I submit a draft to you next week to provide comments on, particularly focusing on the intervention that I have proposed? May I have your email address? Here's my card. I would love to work with you potentially. I tell students all the time, they email me, they say, I'd love to hear more about your research and talk more. And I'm always like, I need you to tell me, what do you want? When do you want it? How do you want it? And I think oftentimes junior scientists feel uncomfortable being that direct, but that is how you move the piece forward. When I met Dr. Fred is my mentor. I met him in 2012 by email. I emailed him. I'd never met him before. He had no idea who I was. I said, Dr. Fred, hi, I am so-and-so. Here is a copy of my specific aims page for my KO1. Would you be a mentor and sign this letter of support and provide comments by next week? Period. The request is crystal clear. And that is what an elevator pitch essentially is. It is a crystal clear request. The person knows exactly how much time is needed, whether they want to or not, and when that request should be fulfilled. It's okay to be that direct.
Yeah.
That's my message.
I'm learning too. Thank you for sharing.
Last one.
We're all learning.
Thank you.
Yeah, mine is also just similar to what Dr. Larissa said. The essence of an elevator pitch is just the way an elevator is. It's like from the time you enter the lift, you've met somebody, and then maybe they're coming off at the first floor. And between the ground floor and floor one, you should be able to state what, why, what you need from them, what it is that you want, what you're doing, what you need from them, and why you think they are important. Just those three things. So it's supposed to be in less than a minute. I am, what's the name?
Well, to be fair, we gave them 90 seconds.
90 seconds.
Tell them 90 seconds.
Okay, but now I'm just giving them an example of an elevator pitch. So you just say, I am so-and-so, this is what I do. I intend to publish this, or I intend to go ahead with this one, and I need your collaboration. And in that time, you'll have finished. So the three things: what you're doing, what it is that you need from the person, and why you think it's important to work with them.
Is that helpful?
Yeah.
Do you want to try again?
Dr. Rachel, take your time to process it. At the end,
If you want to try again.
If you want to try it again, we'll try it again. I would,
No, you don't have to do it now. Not now, just.
No, just have the whole, everyone go, and then at the end, if you have time.
You can come back again.
You can also cut down on you. You spend too much time
Oh,
talking about
you.
your background. I think you just have them across. This is my expertise. This is what I do. This is what I'm moving on to doing.
Right.
And this is what I need from. This is why I need to.
Right.
Yeah, so I think that makes sense because in our preparations, we were supposed to talk about our previous work, our fellowship, then our next step in 90 seconds.
Yeah.
So that's why you find that now the what and the why cannot be put in that in the 90 seconds. If you tell me to discard the past and focus on the now, I will sure take the 90 minutes with what I want now.
Yeah. So you still can talk about it, but I think you can be more concise. This is the work that I'm doing. I just finished CHILD-GRF fellowship. I am publishing. I'm a productive scholar. I'm publishing. This is what I'm doing next, and this is why I'm here. This is what I need.
Is that fair?
Yeah, that's fair.
Yeah. All right. If you want to try it again, then then
We'll come back.
We'll come back. Okay. who's
Harriet.
next? Dr. Harriet.
So
Well, being second is also hard now that you're.
Uh-huh.
Right. Okay, well, wait.
All right, whenever you're ready.
Yes, good evening, everyone. My name is Harriet Ejilong. I'm a practicing pediatrician and lecturer at Gulu University. Do you know that vitamin D deficiency is a common problem even in sub-Saharan Africa, where we have sunshine all year round? Well, in the study that I did, we found out that 75% of the adolescents with HIV and depression actually had vitamin D deficiency. So my area of interest is that I want to explore the use of micronutrient supplementation to improve the well-being and health of not only children, but also adolescents, including their mental health. So I am looking at screening for vitamin D deficiency, but also use of micronutrients to actually manage some of these conditions. So in my next study, I really want to look at the causality or the causal relationship between vitamin D deficiency and depression, so that we can look at supplementation as an alternative therapeutic intervention for depression in adolescents. And my ask is actually that I want to get partners or experts who have done micronutrient deficiencies and such an intervention to improve the well-being and health of adolescents and children with HIV. Thank you very much.
Okay, thank you. Thank you. Oh, I heard vitamin D deficiency is your overall interest. You've done that in terms of, you've looked at it in terms of, adolescents with HIV, 75% of them being deficient. And so you want to now see what's the link with depression. So you want to now see vitamin D, does it have some mental health implications with depression, right? And then your access partners, who else has done this kinds of work, and particularly as related to depression? Does that make sense? Okay. So I think I see the axe, at least it's there. Yeah, you're looking for collaborators for sure, is yours. And I think it seems to be, and I don't know the research, but it seems to me that you're saying adolescents living with HIV are suffering from depression, and could they also be deficient in vitamin D? And so maybe if we increase supplementation, we may not only address the vitamin D deficiency, but we may also get to the bottom of depression. So there's some innovation there, which is good, because it piques the person's interest, especially if they have experience there. I don't have too much to say unless anybody has. Go ahead.
I agree fully, and great presentation. One thing that your ask was for collaborators, and I have been in your shoes many times. One way that I found to even pinpoint that even more is to make a list in my mind about the types of collaborators I want. So sometimes I think about what's the expertise I bring. I'm a behavioral scientist. I can design the study and work on the behavioral measures. but I might say, I'm looking for a statistician, right? I'm looking for a clinician. I'm looking for a community leader to open recruitment opportunities. I'm looking for a government official to, provide approval for me to, like, so sometimes in your elevator pitch, if I'm approaching Dr. So-and-so and I know that she is a clinician, you could say, I'm looking for clinicians. I'm looking for epidemiologists. And that tells the person that the ask is for them, not just collaborators and experts in general.
I think it's helpful.
Thank you. I think I heard you say something about people who have done this type of intervention, right?
Yeah.
Yeah. So I think to Dr. Larissa's point, is that from a clinician perspective, is that from a researcher perspective, so I think it's just very minor, quite frankly, just a clarification so that it's even more focused.
So why do I need the collaborators? One, I want to learn from the experiences. What did they go through? What were their challenges? What were their successes? So that I can build on what I am actually
Do
doing.
you want them to work with you, or is it that they will mentor you, but you're leading, or is it that you want to work with them on this new area together?
So I would want them to mentor me as a lead. They would be guiding me actually.
But
as a
you would
mama.
lead, they would guide you.
Yes, please.
All right. So then I think another thing then is to think of being indispensable. What is in it for them? Right? So it's not just, because these collaborators are busy.
Yeah.
And so you have to be proposing something too that will be innovative for them to be able to say, let me now enter and mentor you. Right? So it's not, so in other words, do your homework on them to see how you help extend what they also do.
Okay.
Does that make sense? So it's not only that I want you to come and help guide me, but here's what I will add to your body of work as well. Does that make sense?
It does.
Yeah. I'm sure you can attest to that. Like, what did you add to Dr. Fred's work?
Mental shift I had to make years ago, I feel like I was a is to stop thinking of people to teach and guide me and start thinking about people to work with me
Exactly.
for the same reason. So I'm adding people to my proposals as co-investigators, not as mentors. Even though I want to learn from them, don't pitch it that way because that's not
Because you're a
appetizing.
pediatrician, right? She already has expertise.
Yeah, absolutely.
So don't bring yourself. There's still
Yeah.
things you have that they themselves may need, right? And so what are you adding to them? Is that fair?
Yeah. I get
Yeah.
it.
Do you have
Yeah.
any questions, any clarifying questions on any of the comments?
Yeah, just a question. What am I adding to my mentors? I think when I publish and add them on a paper, on a publication, isn't
It's
that
not
good
enough.
enough?
It's a lot to work with people. So what she's saying is at some point, the lines are drawn where they're no longer mentors, but your colleagues. You're going to get there, especially if you've worked with people for so long where they're learning from you, you're learning from them. Does that make sense? And that's how you want it to be, where even if they begin mentoring you, at some point you're teaching them too. And in a good relationship, everybody's learning from each other. We're all lifelong learners, And so always think of what am I adding to them too, given my expertise, given what in other words, what do you bring to the table for them? Just as much as what are they bringing to the table for you? Does that make sense?
Yes.
Yeah.
Thank you.
So it could be that they're doing this work, but not with people living with HIV. And then you're
Exactly.
just kind of like expanding.
Or they're
their
doing
work,
depression.
Or they're doing adults
Yeah.
and then you're doing children and
Exactly.
adolescents, So
I like that. Yeah.
thank you. All right.
All right.
Dr. Andrew.
Edgar. Thank you. So we're learning.
It gets better. Okay. Wait.
Oh, dear. Good afternoon.
Good afternoon.
My name is Andrew, and I'm a behavioral scientist. And I have a keen interest in understanding adolescents and their transitioning in care from pediatric to adult clinics, HIV clinics. So over the last 6 months, I've been doing a study to understand why adolescents have trouble to transition from pediatric to adult clinic. And I found that for many of them, the daunting adult environment and the fact that they're just transferred and not transitioned into care affects them to easily transition to the adult clinic, which affects their adherence and viral load. This is the good news. I have co-developed an intervention, which is going to look at how we can work together with the young people to transfer them easily from the pediatric to the adult clinic, where they work together in pairs to move from one stage to the other. And we want to test this intervention in 3 health facilities. However, we lack resources and funding to make this a possibility. I'm looking forward to working with these young people to make sure that they can be able to test this intervention, and if successful, then we can roll it out to the other transition clinics in Uganda. And so my interest is to make sure that we can raise resources to have this pilot done, which will inform the generation of data into a bigger study. Thank you very much.
Ooh. So this is my language. So adolescents transitioning to care, trouble with transition adherence and viral load, and you have developed an intervention where adolescents are transitioning as pairs. Is that what you said?
Yeah.
So like 2 adolescents transitioning together,
Yes.
like a buddy system
Yes.
kind of thing. Okay. But you lack resources. Okay. I want to believe it exists already, buddy systems, right? What makes your own different?
What makes it different that it exists in other places, but doesn't exist in Uganda.
That's not enough.
And also the fact that for many of them, even
Okay.
where it has worked, it's not been as
Say it
successful.
again, the way?
Where they've had the buddy system,
Okay.
it's not been as successful in dealing with issues to do with adherence to.
In what way?
So, for example, many of the young people don't end up attending the clinics, and so we want to do one where we co-develop it with. So many of them they've been developed, and then they issue them to the young people. But whereas this one, we're going to co-develop it with the young people, and then we use that co-development where they're sharing their views. We're listening to what they want us to actually do and use that to actually create this intervention rather than just developing an intervention and then throwing it up to them.
I think that's where you want to start. You're co-creating a buddy system.
Right.
With adolescents from the bottom up.
Yeah.
And in the way that hopefully they own the process,
yeah.
as opposed to top-down, expert-driven.
Yeah.
Because buddy systems exist, people have done that, but like you said, it has not been effective. And so in this scenario, you want to build it with the adolescents from the ground up, and with the idea that if you do that, it might be different and may address those other issues.
Yeah.
So lack of resources, do you have a sense of where you're going to look for funding or?
So actually, because this is a pilot study, we have applied for a care grant to give us some resources to be able to pilot this.
K43 or which one?
K43, yeah.
Nice.
And if
Are
it's
they
successful,
discussing it anytime soon or?
I'm not sure, but we just put it in 2 weeks ago, so hopefully.
K01, is this a K01 or which one?
K43.
K43 was, okay.
Is this in real life or?
Okay. No. I'm trying to see. No, if it's real life, I thought K was due in the December, but maybe it's.
No, I haven't put it yet.
Okay, that's what I'm saying. So I'm thinking real life kids were due in December, so that means they're discussing them now. So that's why I'm like, are you being discussed now? But no. So you're trying to put in a K-43.
Yeah, that's my plan. I'm writing up something.
You have to remember K-43s are about training. It's a
Right.
training grant, not necessarily a funding resources grant. And the funds they give for Ks are like 30,000.
Right.
Part of it is it funds your salary, not necessarily the whole idea. So
Yeah.
keep that in mind that it's still a so going back to your thing, I would do a small RO3. Remember when I said in the beginning when I just wrote small research grant, the fact that buddy systems have worked,
Right.
but they've been expert driven and they have not necessarily led to change as you would want to see in Uganda. So it's evidence based.
Yeah.
That's why I started there. Buddy systems are evidence based, but they've not been used in Uganda in the way you are envisioning it.
Okay.
What if we use that evidence, but in a different way in Uganda? That's a small RO3.
R3. Okay.
And I believe NICHD is in that one.
Ah.
So that's a small adolescent RO3 grant that gives you 50,000 across 2 years to do this work.
Good.
So anybody else?
Dr. Juliet.
Completely agree with all of the advice given. I've been on a few study sections now at NIH, and I've noticed that sometimes the authors make the case for their country.
Yeah.
But the applications that have the highest scores are the ones that say, we want to answer this question in China to inform Asian context, or we want to answer this question in Tanzania to inform sub-Saharan African approaches, or we want to answer this in Texas to inform, South American context. So when you're pitching it, make sure you situate Uganda as a context to answer a larger question.
Larger question. Okay.
Does that make sense?
Good. Yeah. Thank you very much. Appreciate it.
Okay.
All right. I'm gonna keep us moving. Is that okay?
Yeah.
Yeah.
Thank you.
Thank you.
Thank you very much.
That's great. Okay, Dr. Jamali.
We're back. All right. Time.
Anytime now. No, not yet. Okay, now.
1, 2, 3, go.
Hello, my name is Dr. Damalina Lwanga. I'm a pediatrician and early career researcher and PhD candidate from Kampala, Uganda. Now, with HIV-infected children surviving longer, it has become critical that we help them thrive. And we know that HIV actually affects how these children learn, how they memorize, how they reason, and even how they speak. Interventions have been designed to try and address these problems with varying results. Now, we know that in order for these interventions to actually work, we need to place them in the hands of people who can implement them and who know what is at stake. So my current work is looking at what caregivers know about what HIV does to the developing brain and what they do about it in real life to try and support their children. And the long-term plan is for me to develop an intervention, training program for these parents and guardians to train them on how to support their children to learn and later become productive adults. Given your background, your work in family health, in family strengthening, I'd like to collaborate with you on developing this particular program and testing it in Uganda. Thank you.
Okay. So collaborators, you're looking for collaborators then. Okay. Yeah. Yeah. So what are you going to give to them? What are they gaining from collaborating with you?
So this is going to be an intervention that we develop together
Co-develop.
and test and eventually implement. So they would be co-developers to the
Right. So my point
intervention.
is they already have family strengthened.
Yeah.
What are you?
So
make them-
I chose the expert in family strengthening because this is what it would take. It would
Right.
take strengthening a family to be able to make time to engage a child, to play with them, to be able to stimulate them.
Okay.
And that requires the family to work together
Right.
to achieve that.
Right. So I don't know much about family strengthening, so just excuse me for a moment. But I want to, well, what if family strengthening is already doing some of that?
So the family,
or are they not doing any of that? That's
the
because
family
I'm just sticking to the word family strengthening, right? I want to assume they're already doing stuff with children.
Yes.
So what are you
So-
doing differently for them?
Okay, so I think the family strengthening is to address issues around stigma. So
Okay.
they're also doing work with HIV-infected children, but
Right.
to address certain other issues, social issues around stigma and, things like that. So I wanted to use that approach, except to strengthen their neurodevelopment
So now you're
practices.
talking. So neurodevelopment plasticity.
Yes.
Okay.
In order to help HIV-infected children to learn better and, their reasoning to develop so that they can become productive adults.
Okay. All right. Anybody else?
I love this study. One thing that I have done too in the past sometimes is to propose a new methodology for measuring. So you mentioned your first step was to do the qualitative study. You could ask or pitch about a new way of doing that information to get more insights from parents, such as photo solicitation or couples interviews or family interviews or direct observations through video or other kind of checklist things. Just noting that sometimes the innovation we propose is through our methods, not just the intervention.
Yeah, I agree.
Any other comments?
Any thoughts?
No, I think that's a good idea for me to actually get a comprehensive information from the qualitative study I'm doing that will then inform what sort of training program I need to come up with, because you need a training program that actually is contextualized and is likely to, work in this in this particular setting and in this particular area with neurodevelopment, because like I said, it's been used, this family strengthening has been used elsewhere, but can we now use it also to strengthen the neurodevelopmental
Neurodevelopment.
practices in the home and things like that? So thank you. That's very useful.
good. Thank you. Thank you.
Okay. You wanna try it? You don't have to. You have like, yeah, we have like. So, only if you want,
Is it helping out? See what other people do?
Yeah.
Go ahead.
Okay, good evening. My name is Dr. Rachel Alnaitwe, a practicing psychiatrist, a researcher, and an active scholar who recently completed a D43 research fellowship. I am currently working on my PhD, looking at the unmet needs of caregivers for older people with dementia, and I intend to develop a feasible and acceptable behavioral modification intervention for the African context. As an expert in behavioral interventions, I request that you collaborate with me on this work.
It's okay. No, we can pause. We can pause. I mean, we're getting.
That's it. Good job, everyone. Thank you. All right, yes, we have. Okay, yes. So if you want to get up, stretch, we're waiting for our last group to come back. And then we're going to have our fireside chat with our Minister of Health and Bishop at 4:15.
So, hi, hello, everybody. We're just about to start our final session, and I think it's really going to be an interesting session. We are expecting Professor Fred and the minister to come in shortly. I have a humble request that we try to fill the chairs to the front because it looks a bit awkward that all these seats are empty. Would that be okay for some of us to move forward? Yeah. Thank you. Yeah. Honorable Minister, you're most welcome. Yes. Great. So I'd like to welcome us to the final session of the 2 wonderful days we've had. Honorable Minister, it's good to see you. Yeah, and thank you so much for really making time to be with us. I know you've had a very busy schedule, but we're getting to the end, and we're going to have a wonderful session with you on the panel. I will invite Chelsea immediately to talk about our next session, and then we'll take it on from there.
Great. Welcome, everyone. We're really excited to have this opportunity to have a fireside chat with the Uganda Minister of Health, the Honorable Dr. Jane Ruth Acheng, the Bishop of Masaka Diocese, Dr. Severus Jumba, and our lovely moderators today, which I have the pleasure of welcoming. Laura Benoit is the director of the McDonald Scholars Academy here at Washington University in St. Louis. The Academy provides the network the Academy provides the network with Washington University incubates new ideas and mentors future leaders. In her role, Lara directs the scholars admissions process, co-teaches the leadership seminar and communication skills, and unites the McDonald Academy seminar community. Lara also works to attract the most talented and leadership-focused international students to Washington University. Additionally, she partners with the Vice Provost for the Graduate Education and International Affairs to build bridges both within Washington University and with external partners to expand the university's reach and awareness. Welcome, Lara. Thank you.
Well, good afternoon, everyone. Thank you, Chelsea. Yeah, we should try that again. Good afternoon, everyone. And again, thank you, Chelsea, for the warm introduction. We have been very busy over at the Academy. We had 1,800 applications this year for 25 spots in the McDonald Academy. So you can imagine, just do the math really quickly. I think I finished my 82nd interview today. So we're very close to the end where we will select our next set of scholars. I do see a few scholars in here. Thank you for joining us in this opportunity. What a pleasure for me to be able to sit here and have a fireside chat. I know that you all have met both of my fine guests prior to this, and they have talked a little bit to you about their thoughts. Now it's my opportunity to learn a little bit more. I thought I would start with a question for each of you, and that is, yesterday I know that you spoke about your ongoing collaborations with iChad, and this is when you need your glasses. I'm just having a moment, a senior moment here where I could just think, oh, it's real tiny print all of a sudden. You get a little nervous, the print gets a little bit smaller. So you talked about your ongoing collaborations with iChad and how you work together to alleviate poverty and improve the health of children and families in Uganda. Will you share with us how you and your institutions benefit from the collaboration in the research with iChad and with Washington University? So I'll have you start, Minister. No, it's kind of tricky. Well done. There we go. Perfect.
Thank you very much, Laura, and thank you for helping me out there. First of all, allow me to thank iChad and Dr. Fred Sewamala for inviting me here. It is not the first time we are meeting. We met some time back, about 2010, 2011. And that is when I first got to know about iChad and the work that he is doing in Uganda. Obviously, the work has been more in Masaka area, and the bishop will talk about it. But I know a lot about the research because he willingly shares the research he's doing. We need that research evidence to inform policy, which policy then we implement as government. So the work has been focused on an area that was largely affected by HIV, and many of the children were orphaned. So we had child-headed families. And so the evidence coming gives us information on how to address some of the vulnerabilities that these children face, including poverty, challenges with education, mental health, and many others, challenges with going back to school, what they can do. But it also opens a way to address their socioeconomic difficulties. And it has been very helpful for me, a policymaker, that I get evidence that I can translate into real work, not only to support the very area where the research is going on, but extrapolate it to cover the entire Uganda, because the HIV scourge has been a big burden in Africa, and Uganda, as you're very much aware, had a very high prevalence, all the way from 18, now down to about 5.2%. But that means the number of people living with HIV are very many. They're only alive because they are on treatment. And the children are also alive because they are on treatment. But being on treatment does not mean that your social needs or other needs have been dealt with. And those needs are the most important because they will determine whether you can survive. If you don't have food on your table, you can't take medicine. If you are not mentally sound, there are so many things going on in your mind, you won't take the medicine. If somebody is not caring for your younger siblings and you have to do it, then you won't progress in life. So what iChad is doing is a game changer in the lives of our adolescents and young children. And it is a lesson that as government, we continue to pick, even as we look at expanding education to bring on board universal primary education, universal secondary education. You don't just open schools and say, go to school when you've not addressed my needs at home. So that gives us information why some of the children are not in school and why they can't keep at school. So when we address some of those social needs, then we are able to keep them in school and they will progress in school. So allow me to appreciate iChad for a very good job and really to again to appreciate the fact that not only are they doing research in that area, but they're also building capacity of other young people to continue carrying out research in that area. We need the capacity. Because one, we lack capacity for research in Uganda, but also research specifically focusing on adolescents and young children is a very delicate area. And it needs skills, it needs time, it needs patience, it needs resources. And I was amazed. Several times they've gone to Kampala. Perhaps I open the meetings and I go away. But yesterday I had the opportunity to listen to some of the students here. And I must say I was very impressed. So again, congratulations. We need more capacity built for our young researchers. Let me stop here. Thank you.
Well, before you put that down, I do have one follow-up question. As a pediatric expert and policymaker, is there a specific policy that you feel very proud of that you have worked with iChad or with their data to implement?
I don't practice pediatrics anymore.
I know, but you're still an expert.
Well, maybe, but back to policy. We have had lots of policies that we have used information that they have generated to work on. Our policies on sexual and reproductive health, our policies on school health, the Child Health Act, and the Mental Health Act. I think the most recent one has been the Mental Health Act, where, lots of information was gotten from the research that he has been doing.
Thank you. And to you, the bishop, I know you have worked for a long time with iChad. So the same question. How does the collaboration with iChad help you do the work that you aim to do in Uganda?
Thank you. Permit me once again to appreciate all the team that has made this two-day conference happen. And in a special way, I want to appreciate the iChad team in Masaka Diocese. As Dr. Rora points out, it's a long-standing collaboration with the iChad. You can say with Fred, beginning way back in 2004. I was then part of the administration of the diocese, but I was dealing with the finance, and the finance people are very busy. I couldn't follow everything. Fortunately, my colleague, Father Joseph Kato, who started with the Dr. Fred Sawamala, is with us. How has this collaboration helped? Thank you, Dr. Honorable Minister Achen has said it informs policy. The research iChad carries out informs policy, not only of government, but also of the diocese. In the next 2 years, I'll be holding a diocesan synod. A synod is a kind of council, general council of the diocese where everybody is involved. The laity, who make the biggest percentage of our group, the religious and the clergy, and in the spirit of Francis, even non-Catholics are invited to contribute because we all live in the same locality. In that synod, we shall be planning for the schools we founded, and thanks to government, some of these schools are also government aided. This means we found the schools, they belong to the church, they are constructed on our land, but also government comes in to support the initiatives of the church by paying salaries, contributing school materials. So if we know how the people we are planning for stand, in this particular case, the children in schools, in matters of health, in particular this epidemic which has been with us for so long, since the 1985s, we put in place interventions that make sure that these children remain in school. In particular, we are very concerned about nutrition. And I should also mention, Minister knows it, the first organization to make a very special intervention when HIV AIDS hit in the region was a church group of sisters called the Sacred Heart Sisters, and the organization was named Chitovu Mobile. Chitovu is where the C of my diocese is seated. And then these were going out into the families, assist the victims, but also the caretakers, and eventually they took on the orphans. And we are building on the same experience, but now it will be more, and it is being more strengthened because we have data. We make decisions not on mere assumptions and speculation, but we get the data from Mr. Sebamala. And here we have been talking a lot about sustainability. This already is looked into by iChild in our diocese. They created savings groups, meaning that now the family will be able to have their own income generated, be it at a small scale, but that's a good beginning. Then other efforts will come in, government and the church, to push this forward. And also in terms of personnel, because when we are collaborating, we collaborate basically on resources, and the human resource is crucial. Mr. Sebamala, when Bishop, whom I succeeded, passed on, he dreamt of a brilliant idea that this bishop should not be forgotten. And then they instituted a provident fund, and many of you have contributed to it. Thanks to Aisha, they have contributed over 80% of that fund. It's now in the realm of almost 30,000 US dollars. What is this fund going to contribute? We thought, they consulted me. I didn't contribute initially, but I was consulted after the idea had been conceived, that how can we use this provident fund? I am very passionate about agriculture because I know my diocese, 85%, even more, it is actually 95% of the population are rural, and they depend on agriculture. Then I suggested to them, let's use this fund to take young men and women to agricultural farm school, or what we call farm schools and farm institutes initially. When these people come back, I expect that there will be extension workers. And the agreement is clear. At least 2 years, you serve within the diocese of Masaka, and you empower the farmers. If they produce crops, they keep birds and have eggs. Do you remember the eggs question yesterday? Yeah. Nutrition of these kids will be improved, but also the income of the households. And to case show how this is open to everybody, one of the first beneficiaries is one lady called Aisha. it was just by coincidence that she had approached me, Bishop. I had a husband. He had taken me to school. I had started the course in business management at Nkosi University, but our relation turned sour and he said, I'm not continuing. So when this fund came, this is the only exception I introduced in the initial beneficiaries. I said, even if she's doing business administration, let's give her a chance. And she's back to school, very happy. In the first credit, she got a 60, and she was on her knees apologizing. Bishop, I've been out of school for so long. That's why I have a 60, but the rest were above 70. I told her, you can do better next time. So this also is part of iChild. When this fund grows and the beneficiaries are faithful to our agreement, and I know they will be, because the selection is also very stringent. There's a team of iChild in Masaka who sieves these candidates. Then they will support the families. The families will continue to be productive, and maybe some take their children to school, feed the victims and non-victims well. And so we are eternally grateful to iChild.
So it sounds like nutrition and farming entrepreneurship might be good focuses for what's next for the church in Uganda. I'm wondering, what are the emerging areas that you're seeing, Minister, that iChad might lean into to help you develop some additional data to inform some new policies?
Well, thank you very much. That is a great question. iChad has been doing a lot of work on adolescents and children. We have a vulnerable group, and that is the young women. Many young women who drop out of school, many young girls who get pregnant while at school and drop out of school. And then there are, of course, the vulnerable ones who separate with their husbands. There is a trend that we are seeing these days, with due respect to men. Yes, with due respect, we are seeing families breaking down, and the men are not concerned about the children that came out of that family. So USAID has been running a program that they call for adolescents and young women, and they call it a DREAMS program that takes care majorly of HIV positive young girls who find themselves out of school, pregnant, separated from the husbands, and so on. But this has been an implementation issue. To me, it would have been much better if some research had been done around the area so that we actually find out the needs of these women. Apart from the needs, how they would prefer to be supported so that it catches a little more fire. Because right now it is like a top-down implementation. We decide what you want, and we give you what you think you want. So for so many years, it has been a program that has been running, but the impact has been very small compared to where we have done research, like in Masaka, and then you know what you need to do to support the people for their socioeconomic needs. Because the needs of some of these people may not be, the utensils we are giving them to do catering, may not be the sewing machines we are giving them, it may not be the money. Sometimes it is a mental health issue. I need to be supported. I need to be counseled. I need to be comforted. Sometimes it is a family issue that needs to be addressed. So I find that a very raw area. If we are really to think about ending HIV among the youth, because right now, the rates of new infections in the youth is going high, especially in Uganda. And yet we are running a race to end AIDS by 2030. Now, we know that AIDS, as I said before, is not, HIV is not only about the medicines. Because for us as politicians and policymakers, we are interested in how many people are on treatment, how many people are virally suppressed, how many people know their status. But what happens at the back door is a lot more to keep people on the treatment, to sustain them, and to keep them alive. So the area of youth and adolescent girls and young women is a very raw area, but also it is interlinked to the area of adolescence, because many of these young adolescents will eventually progress to young women. And we have lots of young women getting pregnant right now, started during the COVID pandemic. It is still continuing. Our pregnancy rate is at about 24%, 24, 25, it never goes down. And of course, when it is left untapped, it is also contributing a lot to the high maternal mortality rate. So there is a lot that needs to be done around the area of youth, a lot of research to understand the youth of today. Many of our youth want to adopt the Western lifestyle. But to bring on board the Western lifestyle, there are lots of challenges, connected with it, and with education and so on and so forth. So personally, I would think if CHILD is to venture or to open up, that would be a ripe area to tap into, because still it would help me to continue with my sexual reproductive health policy, because it captures the youth, the school health policy, because these are still adolescent girls and young women whose needs I need to address. And of course, it would still continue to contribute to the evidence that I need for the very many acts that we are working on. So that would be my suggestion. I thank you.
So for the early career researchers that want to do work in Uganda, you just got a front door opportunity to look into. And I was going to say, do you have anything else you might add?
Yes, but just to let them know that 70% of our population are the youth. So 70% is a very fertile area for research. If you go beyond 70%, our group, we are very few. And I think we have lived, because our life expectancy is 68 years. So tap on the youth.
All right. Yes, I was coming right to you. Thank you.
Right, Honorable Minister, you allow me to intervene to soothe a little bit the hearts of men.
We're two-thirds
What I'm
of this
saying,
group here.
yeah, the young adults, girls are more vulnerable, but also the young men are vulnerable. And we agree on that. Yes, because when they are mentally uncatered for, frustrated, they revert to drugs taking, insecurity, stealing. I mean, you can even call it pet stealing, because they're frustrated, they want to survive. Yeah. Honorable Minister mentioned the DREAMS program. My health department, she knows it. We call it Masaka Health Coordinating Office, have been part of the implementation of the DREAMS program. In the father and the team, men and women working with him, reported to me. And one of my concerns was, you bring the girls together, you have already decided what they should do. And by that time, many were doing hair do skilling salon. I asked them, if everybody is doing hair salon, who is going to be the market of the other? Yeah. And they started to see that. Another question I put, where are the boys? Because this young girl is now a young mother. There is a young man or some man somewhere who is responsible. And they said, no, but the donor is very stringent. We cannot bring in the male element. Yeah. So then we agreed that let our catechist talk to the men separately, at least to prepare them mentally that we have a problem. And I hope it had some impact. But if we had had research carried out as CHILD is now doing in our communities, maybe it would have been better re-implemented and would have had a more vivid impact. We must be grateful it has had some impact, because just bringing these young girls, young mothers together in itself was helpful. They supported each other. They understood the problem is not me alone. And now they are aware. Maybe they can do better in the future. But it should be underscored, research is crucial. Yeah. And Chad, please go ahead.
I want to thank you both very much for your comments. I think this has been a really wonderful partnership between ICHAD and the Catholic Church and the ministry in Uganda. I'm glad to hear that there are some additional opportunities where this group here, our young researchers, can find some really, as you said, ripe opportunities to look at some interventions. Don't forget the boys. I think that's some wise advice as well. This was a very brief panel. I know we could have talked a little bit longer, but I know we're almost ready to wrap up. I think my friend Colleen Matar will be talking with the minister tomorrow on the medical campus. So if you would like to hear more, I'm sure they would be happy to have a conversation with you at that point. So we're not going to take any questions today because I'm getting the signal to wrap it up. So one more round of applause for our esteemed panelists. Thank you. Thank you.
Thank you so much. That wonderful fireside chat. And thank you, Laura, for leading us in that. Great way to close out the day. But we're not actually closing out the day because we do have our presentation of CHILD-GRF program completion plaques. So we'd like to welcome our program director, Dr. Fred Seomala, as well as Dean Dorian Traub and Vice Provost Mary McKay, and our PI, Dr. Noli Nakasuja. So please welcome. Yes, that's a good spot.
Thank you so much again. First of all, because I didn't take a chance. Give the closing remarks. For several reasons. So, but I really want to thank each one of you for coming. Okay, thank you. Oh, I really want to thank each one of you for coming. Honorable invitation. Bishop, thank you so much for many years of the collaboration. Our colleagues, Dean Mary, Dean Dorian, and Dr. Noerin Nakasuja, and the ICHA team. Betho, I don't know what I would do without you. Thank you so much, really. Really. And so we are coming to the end, and what we are going to do is we are going to have a graduation. And the graduation is for our three cohorts of CHILD-GRF for completing the Child Global Research Fellowship. They all worked hard and they are all graduating. So whoever is not here is not graduating except for one, but whoever is here is graduating. So we will read your name. My role is to read the name. So Dean Mary already told you is. And so I'll read your name. I hope, either Betho or someone will be able here to come here and hand over the graduation plaque to Dean Dorian. Dean Dorian will be able to pass it on to the graduate. They will shake Dean Mary's hands, Dr. Noerin's hands. They take a picture and then they go, okay? So please bear with us. All right. All right. So, do you want us to come?
No, we'll take it. Okay.
Oh, you wanted this?
Because of this.
Oh, because of that? Okay. But then,
We're fine. We'll carry them.
because this moves. Oh, you want to exercise? Okay. All right. Okay, the exercise. I think you should have told us about the exercise, especially given Mark Huffman's presentation this morning. All right. Yes. They're less worried about you than my complexion. That is dark, so they won't see me.
All right, here we are. You're next to me. Is this right?
So I read it from here. Okay, so that okay. So you are next. So,
The directors are gonna get
all
this
right.
all.
All right.
Yeah.
So thank you. So it takes 4 PhDs to figure out where to stand. All right. So Dr. Rachel Arinaitwe. Dr. Rachel Arinaitwe is a psychiatrist at Makerere University. She's also a study coordinator for the College of Health Sciences at Makerere University. Her mentor is Dr. Dickens Akena, who is also in the room here. And what Dr. Arinaitwe did, she was doing detection and referral of depression among adolescents living with HIV in Uganda. Congratulations. Okay, the next person is, so that's cohort 1. And the next person in cohort, it takes now 2 PhDs to figure out the next one. The next person is Dr. Anita Arinda. Dr. Anita Arinda is an assistant lecturer at Makerere University. She was mentored by Dr. James Mugisha. And her area of interest is HIV education program for improvement in HIV knowledge for adolescents with intellectual disability in Entebbe, Uganda. That's what she worked on. The next person is Dr. Violet Nabate. Dr. Violet Nabate is a pediatrician who works with Nakaseke General Hospital in Uganda. Her mentor was Dr. Barbara Mukasa, who is not with us here. Her research was on prevalence and factors associated with depression among adolescents living with HIV in care at Mauldme, Uganda. The next person in cohort 1 is Dr. Justin Diana Namuli. Dr. Diana Namuli is a psychiatrist, lecturer, and a PhD bioethics fellow in the Department of Psychiatry at Makerere University. Her mentor was Dr. Janet Nachigude, and how she focused on the burden types and lived experiences of HIV stigma and associated factors among HIV-infected children and adolescents, a mixed method study in Uganda. So that concludes our cohort one. Three members of the three cohorts are not graduating today. That's fine. Yeah, that's fine. So our cohort two, we are starting with Dr. Raymond Atwebembere. Dr. Raymond Atwebembere is a research assistant at the International Center for Child Health and Development. He's also an MPH student here at Washington University. He's blessed to have his dad in the room, Dr. Ebo Mwebembezi. And his research is, he was mentored by Dr. James Mugisha, who is also in the room. His project was association between depression and suicidality among children living with HIV in low socioeconomic settings. Congratulations. Yeah. I think, yeah. That was an urgent call. They wanted me to do surgery, but I told them I'm not qualified. So, oh,
Whole family. Congratulations.
so the next person in that cohort, I lost where I was. Okay. Okay. Doctor, but where is number 2? Oh, no, that one actually was cut out, but she's very, yes. Dr. Agilongo Harriet. Dr. Agilongo Harriet is a pediatrician and lecturer at Gulu University in Uganda. Her mentor is Dr. Victor Musime, who is not here with us. And she studied association between vitamin D levels and depression among HIV positive adolescents in post-conflict northern Uganda. Congratulations. I got it.
But it does jump.
Yes, I get it. The third person is Dr. Richard Impango. Dr. Richard Impango is a senior lecturer at Soroti University in Uganda. And his mentor is Dr. Eugene Chinyanda. He focused on evaluating the effectiveness of the new forest parenting program to mitigate behavioral problems and improve adherence outcomes among children and adolescents infected with HIV and AIDS. All right. The next person is Dr. Andrew Sentongo Semata. Dr. Andrew Semata is a doctoral researcher at Makerere University. He's being mentored by Dr. Eugene Chinyanda, and his research focused on transitioning from pediatric to adult HIV care services and its impact on adherence and mental health and well-being for adolescents and young people in Uganda. So that concludes the other person that really completed our work is Dr. Yvonne Karamaji, who is not with us here because she just took on new responsibility at Mildmay. She's now the executive director of Mildmay. So Dr. Karamaji is not with us. So our last cohort, last but not least, cohort 3, is we start with by inviting Dr. Edgar Guma. Dr. Edgar Guma is head of psychiatry department at the General Military Hospital in Bombo. He was mentored by Dr. Dicken Zakena, and his research interest is mental health and violence against children living with HIV in Uganda. All right, the next one is Dr. Letitia Chomhangire. Dr. Letitia Chomhangire is a scientist and medical researcher at the Medical Research Council. She's a study coordinator for Uganda Research Unit Psychiatry and also works with Uganda Virus Research Institute and also works with Butabika Hospital in Uganda. She was mentored by Dr. Eugene Chinyanda, and she focused on integration of management of common mental health disorders in children and adolescents in routine HIV care. Congratulations. Okay, then the third one is Dr. Emmanuel Mpamizo. Dr. Emmanuel Mpamizo is a lecturer at Gulu University in Uganda, and he was being mentored by Dr. Catherine Abo, and his research focused on prevalence of alcohol use for children and adolescents born with HIV attending HIV/AIDS clinic. And last but not least is Dr. Damari Narwanga. Dr. Damari Narwanga almost missed the event because her plane was almost delayed. But Dr. Damari Narwanga is an assistant lecturer, Department of Pediatrics and Child Health at Makerere University. She was mentored by Dr. Philip Musoke, and she does work on neurocognitive functioning among HIV-infected children who are hospitalized for severe pneumonia. Congratulations. All right. So that concludes our award ceremony. Thank you so much. Now, we also want to recognize some mentors for the scientific leadership of implementing the NIH CHILD-GRF training program as mentors. So we have Dr. Dickens Akena. So Dr. Dickens Akena is one of our premier mentors. So thank you so much, Dr. Akena. We have Dr. David Kawa Mafijiri. Dr. David Kawa Mafijiri is one of our also premier mentors. And I'm very proud that we graduated from the same college. He was my classmate. And then we have Dr. James Mugisha. I think, during the year I was born, I was lucky because I also know Dr. James Mugisha as a child. We used to go to steal the mangoes together. Okay, we shared on the mango trees together. So those are our mentors. But we also want to recognize the following people for their scientific leadership implementing the NIH-funded CHILD-GRF training program. Dr. Mary McKay. Congratulations, Dr. Mary McKay. Dr. Noeli Nakasuja. And another person called Fred. I don't know.
Oh my, what a.
Oh, all right. So continuing with the award, we also want to give our award to the people who have really been providing, leadership in terms of data management. We have Miss Rebecca Warugembe, who is the trainings coordinator. Then we have Miss Harriet Namboze from Makerere University. We have Miss Laura Pia from Washington University. And then we have Miss Chelsea Handsheldon. And this was a Ugandan thing, so that is what they call Uganda iChard Field Office, which is being represented by Miss Sanyu, Miss Rebecca, Miss Rita, and Miss Fiona, if they could come and get their own. Yes, all right. Please. Yes, okay. Thank you. All right. So as you all know, when you are working on, I told you it takes a village. So when it takes a village, there are several people who are involved. So we have two co-investigators on the child GRF that we conceptualize with. And the first person is Dr. Ozige Senso Ibaha. Thank you so much, Dr. Ozige. Oh, my. Oh, thank you. Okay. Then Dr. Proskovia Nabunyu. All right. Oh. And I just showed the Honorable Minister and the rest where all this happens. All this happens here at the Brown School. Without Brown School, we wouldn't be able to do this. And we are honored to have our dean with us, so the Brown School, on behalf of, thank you so much. All right, so we have, I understand the dean, I don't know whether she has more time, but I understand she wanted to leave, but we have a few collaborators. Oh, okay. She has another event, but we'll go ahead and she will honor us. So for years of collaboration with iChad, we'll go ahead and call the Right Reverend Bishop Jumba. And Reverend Father Joseph Katobakuru. Father Kato. Miss Harriet Nambozo from Masaka Regional Hospital, I think. Masaka Regional Hospital does all our blood work, and she's in charge of that. So we're extremely grateful for the partnership. Dr. Ebo Mwebembezi, Reach the Youth Uganda, our implementing partner. Mr. Timothy Opopo, for years of working with us. So all the policy work. Yeah, all the policy work. Come and get us right here, please.
Hello.
Please, please. Yes. All right. Thank you so much. All right. All right. And we have Mr. Ayo Odong for our partnership with us and moving us forward. So all right. So I want to thank you again for coming. I want to thank you so much for staying this long. This concludes our event. There are no, unless there's something else to announce, but we want to thank each one of you. Travel safe, be careful, enjoy St. Louis. A lot to see, and enjoy Washington University. Thank you so much.